Okay, good evening. This is the last part of um, lecture about management of impacted teeth. In the last two lectures, we talked about how to manage impacted teeth in general, principles of managing wisdom teeth specifically. And today we're gonna just talk about also general principles about managing other impacted teeth, showing some clinical scenarios. Let's talk about maybe another impacted teeth that we may face in the clinic. Here we're talking about impacted premolars, and we mentioned in our first lecture that third common impaction after wisdom teeth and canines are premolars, especially lower premolars. So here we have a lower secondary premolar that has no space, and it's completely impacted underneath the soft tissue and bone. So how to manage this tooth surgically? First we have to expose the tooth and the overlying bone by reflecting mucoperiosteal flap, and the size of the flap depends here on the amount of exposure we need, depends on the depth of the impaction and angulation of the tooth. And in this case, the surgeon raised a full mucoperiosteal flap, rectangular flap, or what we call a four corner flap or three-sided flap. And as you can see here, the vertical releasing incision was done one tooth anterior and one tooth posterior to the impacted tooth, and the flap is reflected, showing them. Here you can see the root of the adjacent premolar is exposed, and there's a bulge in the bone that represents the bone overlying the impacted premolar. A very important thing when you are doing any surgical procedure in the lower premolar region is to protect the mental nerve. So you have to identify the mental foramen and then protect the mental nerve. So you see the nerve first, protect it from any sharp instrument by retracting the soft tissues and the nerve away from the sharp instruments. So after raising the full mucoperiosteal flap, you start exposing the impacted tooth. As you can see here, part of it is exposed, but you need to expose up to the cement to enamel junction or below it in order to section the tooth at the cement to enamel junction. So you can use here for removal of bone, you use round burr. Sometimes you can, of course, use a Fisher burr, and you use Fisher burr also to section the crown. After having a good exposure of or removing a necessary amount of bone and exposed a good amount of the tooth, you identify where the cement to enamel junction, because this is where you're gonna section a crown from the root. So using a Fisher burr at cement to enamel junction, you section the crown. After you create your groove here, you place your elevator, rotate your elevator. So by doing so, you separate the crown completely from the root, and then you mobilize the crown buccally out of the bone. So trick here, you need to create enough window bone or bony window in order to remove the crown outside the jawbone. After removal of the crown, then you have the roots still in there. You can create purchase point in the root structure using round burr in order to apply your elevator and elevate the tooth. So as you can see here, purchase point created. Then using a Cryer elevator, you remove the tooth or the remaining root occlusally outside. You can see here, you mobilize it occlusally, and then the final movement, you put your either straight elevator, Cryer elevator at the tip of the root, and then you have it out. After you're done with the extraction procedure, with the tooth is out, you need, of course, to smoothen any sharp bone using large, let's say, acrylic burr here, large burr, in order to smoothen the bone. Of course, you need to do some irrigation to clean the area. make sure there's no bone debris or parts of the tooth there. Then you close your flap back again using either resorbable or non-resorbable suture. The suture used here is silk, which is non-resorbable suture. Here's another case of impacted lower first premolar. The impaction is a bit deeper. Maybe the angulation is favorable, we don't know. You can't rely on 2D radiograph. Nowadays, best practice for any impacted tooth is to take CBCT, cone beam CT scan, in order to localize the tooth accurately within the jawbone. So you can, you know, where we're going to be your approach, buccally, lingually, palatally, buccally. But here, for example, in clinical examination, you may feel or you can see bulge in the area. That tells you that the tooth is lying buccally. So here, the surgeon decided to do another big flap, let's say a rectangular flap, 2 tooth anterior and 1 tooth posterior to the area of surgery. 2 vertical releasing incision was carried out here. Then flap is reflected, as you can see here. We are identifying here the mental nerve bundle going out from the mental foramen, very important, so you don't damage the nerve by your retractors or by your instrument. Then after reflecting full mucoperiosteal flap, you need to remove bone to expose the tooth. As you can see here, we created a bony window in to expose the crown of the tooth using round burr. So before sectioning the tooth, if you think that the angulation is favorable, you just create a space for your Coupland elevator or your cryo elevator and try to mobilize the tooth. If there is no resistance and the tooth is mobile, then you can elevate the tooth without any sectioning. This will save time, of course. So in this case, the surgeon applied the elevator at the cemento enamel junction of the tooth, point of application, elevate the tooth, and the tooth is mobile. So then the tooth is out. So there is no need for the sectioning the crown from the root like the first case. Of course, after removal of the tooth, you need to remove any buds in there, any follicles, sorry, any remnant of the follicles, and you need to smoothen any sharp bone before you close the flap. Let's talk about the upper jaw, the maxilla. As you can see here, is a case of impacted second premolar in the maxillary arch, and from clinical examination you can see there's a bulge in the palate, so that tells you that the tooth is lying palatally, or at least the crown is bulging palatally. Of course, in order to determine the exact location or localize the tooth accurately, CBCT is the best, or you can of course take sometimes 2 different radiographs based on the parallax technique, either vertical parallax or horizontal parallax. So the approach here should be palatally, so we need to raise palatal flap, so incision into the gingival sulcus of the surrounding teeth, and then in the crest of the ridge, where the area where is the missing tooth supposed to be, and then complete your incision posteriorly at the gingival sulcus of the posterior teeth. You raise the flap, the palatal flap. As you can see here, we don't do any vertical releasing incision, just like envelope flap. So we raise the flap. You need to take care of important structure here. Like we have the incisive bundle or nasopalatine bundle. Of course, if you cut this bundle, you have a heavy bleeding. You can control using cautery or any other hemostatic procedure. If you cut the nerve, it's not a big problem. Nerve may regenerate again in this area. And the numbness will be localized only for the premaxillary region. Of course, after raising full mucoperiosteal flap, you need to expose the tooth by removing some bone. As you can see here, removing bone using round burr all around the crown. Then If you think that you removed enough amount of bone, you create like the gutter where you need to place your elevator at the point of application and start mobilizing the tooth. The tooth may come out without any need for without need for any sectioning. Here, the surgeon placed the elevator, mobilize the tooth, and the tooth is out. So there is no need to section the crown from the root. Once the tooth is out, again, you have to clean the area, smoothen any sharp bone, irrigate the wound area, then close it using sutures. As you can see here, the remnant of follicle is removed and suture placed the flap to its original position. Here's another case of impacted maxillary teeth. On the right side, this is impacted canine. It seems that this canine is impacted buccally, as there's a bulge in the buccal side. So you need to raise the flap in the buccal area. So the flap we raised here is full mucoperiosteal flap, a rectangular flap with two releasing incision, one mesial and one distal. As you can see, the mesial one located between the two central incisors, and the distal one is just distal to the primary canine. So the flap is raised and protected using a retractor. You can see the bulge on the bone here above the primary canine. So surgeon started removing bone to expose the tooth, or at least the crown and part of the root below the cemento enamel junction. Once you had enough exposure, you either start mobilizing the tooth. If it's mobile, then that's fine. You don't need to do any sectioning. If it's not mobile, you need to section the crown off. So here the surgeon sectioned the crown away from the root and remove the tooth, remove the crown out. Then you can create point of application in the root structure and mobilize the root mesially or anteriorly. So you get the root out outside the jawbone. Of course, you need to remove any remnant of the dental follicles and smoothen any sharp bone. Very important here when you do this procedure is to be careful not to damage the roots of the adjacent teeth. It's very easy to damage these roots during drilling, removing the bone, or creating or sectioning the crown from the roots. Then, of course, smoothen the bone with the bone file, and then suture the flap back to its original position. Here's another case of impacted canine. Again, it looks like that the tooth is impacted buccally because there's a bulge clinically, as you can see. So full mucoperiosteal flap elevated. The flap here, because the tooth is not high in the arch, it's at the, let's say, very close to the occlusal plane or the cemento enamel junction. So the flap raised here is, I think it is a small flap, full mucoperiosteal flap, three-sided flap, then removal of bone to create bigger window for the tooth to come out. Once you have enough bone removed, apply your elevator. If the tooth is mobile and you can remove it without sectioning, then you remove the tooth out. Of course, you need to smoothen any sharp bone at the end and then close the flap. Here's another case of, again, impacted canine, but the impacted canine here is in the palatal side, not in the buccal side. Maybe clinically, sometimes it's very difficult for some cases to see the bulge clinically. So the best thing is to localize it using radiograph. Sometimes the tooth is lying on the line of the arch, not buccally and not palatally. So we raise palatal flap here, as you can see here. The flap extended from the molar region, the apsilateral side, up to the canine, the other side. We can see here the bulge, small bulge in the palatal side. You start removing bone using handpiece, expose the root. After exposure of the root, the angulation here is not favorable, so you can't remove the tooth without sectioning the crown from the root. So section the crown from the root using Fisher burr, then removing the crown, then removing the root, them clean, smoothen any sharp area, removing any dental follicles, irrigate the wound area, and then replace the flap to its original position and do suturing. Of course, next semester, you're going to talk about the impacted canine in details and how to manage impacted canines, to expose them or to extract them, and how to treatment plan patients for impacted canines. So that's it. That's the end of this part of the lecture. If you have any questions, please let me know. Yes, go ahead, Sarah.
Doctor, regarding the first lecture of impacted third molars, الكلاسيفيكيشن difficulty classification نعتمد على التكست بوك ولا النيو classification اللي بالجدول؟
So the most important thing is the one mentioned in your textbook, okay? But sometimes in textbook new things or new indices or new classifications are not mentioned. So you have to cover both the classification mentioned in the lecture and the classification in the textbook. Actually, the one in the lecture, which is it is actually a combination of too many classifications or indices. So there is no let's say there's no difference between these classifications, but the one the one I mentioned in the lecture maybe a more comprehensive classification, taking into account too many factors, more than the one mentioned in the textbook. Any other questions? So just to summarize and sum up things, the most important thing from wisdom teeth lecture is to know how to assist patient for wisdom teeth regarding the treatment plan, regarding the investigations you need to carry out. You need to know the indications for removal of wisdom teeth, when to remove wisdom teeth, when to decide not to remove wisdom teeth, risks versus benefits, alternative options for surgical extraction, complications related to wisdom teeth extraction. And this is very important because you need to inform your patients about potential complications that may arise from third molar surgery. You need to know how to deal with these complications. And of course, you need to know the classifications for classifying impacted wisdom teeth. You need to know the difficulty factors associated with wisdom teeth, and how to decide the difficulty level of surgery using the radiographic indices, the clinical indices, or the clinical factors. For the surgical procedure for third molar surgery is same as other surgical extraction in the mouth. You apply same principles. You need to, of course, you need to know how to avoid lingual nerve injury, how to avoid the inferior alveolar nerve injury, how to assess the relationship between inferior alveolar nerve and the roots of the third molar from plain radiograph, when to request cone beam CT for patients undergoing third molar surgery. Same applies for upper wisdoms. You need to know how to assess them. You need to know how to classify upper third molars. You need to know difficulty factors that increase the difficulty of surgery, clinical and radiographic factors. That's all about wisdom teeth, and it's very important topic for basic oral surgery. So you need to read well about this topic from the textbook, the lecture, and of course, if you have any other information from the clinic, if you face the third molar that need extraction, and you discuss the case with your supervisor, so you can gain, of course, information from the clinical setting. In addition to the information you have from the textbook and the lecture. Any other questions? Okay, that's it for tonight. Thanks for listening, and wish you best of luck in your exam. See you inshallah next semester.